So the question I'll repeat is, do you have a go live date for the system, and what is the expenditures? So what is our, I'll let Ventura County cover, what is our go live date anticipated to be?
Yeah, I'll take that one. The go live date, we estimate that we can have this launched within 6 months of the start of the project. The start date has not been determined because of the the arduous purchasing process, let's just call it. Every purchase goes through many different reviews and things, but we believe that with the help of Opeeka, once we have the green light, we can be up and running within 6 months.
Yep. And so on a technology side, we usually take about 30 days per system integration. So right now that we're talking at Ventura County is one system integration with NetSmart. And so from a technological standpoint, it'll take us about 30 days. The 6 month is a good buffer in case there is any other, red tape with that. There could be some questions from Ventura County IT about the way that things are integrated, and so it can slow the process down a little bit. But from a technology standpoint, it's about 30 days per system. So if you're doing 2 systems, you can think 60 days. If you're integrating 3 different electronic record systems, you can think 90 days. That's about the time. And in terms of cost, Ventura County being the first to go, got a deep discount to be a leader. They are paying $95,000 on an annual recurring revenue for the system. So it's under $100,000 for the behavioral health and child welfare, for the behavioral health piece. And then as we loop in child welfare folks to come online, I believe they have some customer reports, and that is another $24,000. So in total, you're looking at $120,000 annual for that system, which I think is really reasonable. Yep.
Well, and just chiming in with that, we haven't calculated it, but when we think of all the hours spent with data cleanup and the attention to that, we think there's a big cost savings to us, and so having the Opeeka as an additional cost, we think we're really benefiting from that in terms of efficiencies.
Yeah, I will definitely second that, the amount of time we're going to save in documentation and sharing and phone calls will more than pay for that.
I have a couple of different questions. One of them is this it sounds like Opeeka is an intermediary type of system that kind of helps existing systems connect, sort of similar to Traverse, or is it a system that's pulling data out of existing systems and kind of reconfiguring the way it looks like Tableau?
So I can take that.
Okay, good.
Yeah. So it is a combination. It will integrate data into what's called a master patient index or master client index from multiple systems using an algorithm that's been developed over the years that's used throughout California, mental health, for the MHSOAC, et cetera, to merge and link the people from the co-serve programs that they exist in. But then it augments that data with additional questionnaires that can be emailed or texted to families to answer. So if your electronic record system isn't flexible enough to add additional questions that you may want to track on those families, you can do it in our system. And then our system will push that data back in any format you want, whether that be as structured data, as an image, or as a PDF linked back to your record of authority.
Perfect. I guess the other question I had is that this is primarily focused on CANS data, but is there an ability to expand it for like PSC 35? Because it seemed like you were talking earlier about the ability to export the CANS data to the state through their reporting portal.
Yeah.
Could we do the same thing with PSC 35 data?
Yes.
Okay, perfect.
So just for folks, there was a question about acronyms. CAN stands for Child, Adolescent Needs and Strengths. It's a requirement for both child welfare and behavioral health in California to complete it. Different versions, unfortunately, slightly, although many of the questions overlap. And then the PSC 35 is the pediatric symptom checklist with 35 questions that's required by the Department of Healthcare Services for behavioral health. We are completely data agnostic. If you wanted to ask a family what kind of breakfast they feed their children, we could do that as well. So it doesn't matter what you want to do. You calibrate that question in our system like you would in, say, Qualtrics, SurveyMonkey, RedCap, and then that question is available to collect. It's as simple as that. You can calibrate questions and have them ready to go, or texted and emailed to your families the next day.
More about the cost. Does that include unlimited licenses, or is that a number of licenses? And then also, if you do want to add on the additional documents, would that also be like a la carte add-ons?
Sure, so I'll take that question. So our pricing is based on a per member or per patient per month or per year. So if you're a small agency or small county, you're going to pay less than a large one. So we want to make sure that it's, in that sense, affordable. For that cost, if you add, the pricing starts out with you having 200 data elements. So figure each question and answer, that's a data element. So if you go beyond 200, you can purchase a larger license per patient or per person in increments. So we can just meet you where you are as far as what your data needs are. So we have an annual subscription fee, we have an implementation fee, and we serve organizations as small as women's shelters with just serving 50 people or 100 people in a year, and conversations with large payers serving hundreds of thousands. So our software is for any organization of any size, and some even use Pieces as a standalone solution where they don't even use any other software. We don't do billing, though, however.
Follow-up question, are those active users per month, or is it into perpetuity, they've been in the system, and so you have to continue to pay for them?
No, it's just active. So for example, when we work with a payer, one of the big questions they had is, well, we don't want to pay for an eligible member that has zero activity, zero claims, use of the healthcare system. And the answer is no, you wouldn't pay for those folks.
But we can take all the historic data because
Yep.
it has a lot of good information to learn from in your data dashboards. So there's a whole dashboarding system, so you can look at all your historical outcomes across any of those data elements. And we really do encourage you to put in your historic data because that will inform how you're doing currently if you compare to the, but we don't charge for users because we want as many people to collaborate around the family as possible. The charge is really based on the number of people in care.
Hi, I had another question over here. So there was content around reports being able to go back to the clinician around the CANs. Are those reports developed in some kind of an outcome measure or level of care tool? How's that reporting looking?
Yeah, we have a variety of reports, which I think was mentioned several times by Jennifer. Maybe Jennifer, if you could step in and say and let us know what it is you think is valuable about the reports that are available in Pieces.
The question is what
Oh, the question, I'm sorry, I didn't repeat the
reports
question. Yeah, the
will be
question is,
valuable?
the question is what kinds of reports are in Pieces around the child adolescent needs and strengths and why and how will they be valuable?
Well, I have to admit, not being abreast of all the reports that are available with Pieces, but I do remember, and Kate, you'll have to help me. I mean, I have to be honest, everything that Kate was sharing with us, I thought, that has a place in our system. That has a place in our system. There was, I believe, a level of care report, which would be hugely helpful because we don't have a robust system for that, for our throughput. But there was also just various progress reports as well, client progress in treatment. There was also, I believe, reports showing you could plug in kind of like clients and what treatment and planning worked for one client, and if they have like symptoms and situations, then you could look that up and then kind of replicate and see what then would be helpful for your current client that might be in a similar situation. Those are the ones that come to mind, but I know there was also, in addition to the reports, there was also reminders, the ability to set reminders for staff. It's time to complete the cans, it's time to do the treatment planning, things of that sort, just these automatic reminders pushed out to staff to, because we know they have a breadth and depth of information they're trying to accomplish and get through, attend to their clients and attend to the many requirements that they have, and so to have those automatic reminders for them as they log onto the system would be very helpful as well.
Thanks. And I'll just add to that and say that there's a number of standard reports that are there, including a client story map that maps out all of the circumstances, including cultural, spiritual, tribal associations, opinions, satisfaction, symptoms, needs, skills, strengths, traumatic experiences, past behaviors. That's all mapped so that you can quickly see and remember the circumstances of the person you're serving. Because if you've got a large caseload, it's really hard to remember, even though they've told you all those details of their story. So that's a really quick way to see when somebody walks through the door and remind yourself so you're cognizant of their story and you're sensitive to that. Also, we have family reports that we had 200 stakeholders engaged around the state of California to help develop that include flowers that sprout with a watering can to share with families what it is they're working on and what's being watered and what's flowering. So there's just a number of standard reports in there, and then we also have the ability to create custom reports. So custom reports as well in any format you want.
Thank you. And just one more question. Was there a reason, or you guys showed that there were a few questions or domains on the cans that you did not allow to be shared to child welfare? Can you say maybe what some of those were and why? Sorry for the hard question.
Did you guys hear that? No? The question was, why is not the entire child adolescent needs and strengths shared between behavioral health and child welfare HSA? Is there a reason why you don't share parts of the cans between the two organizations?
I can definitely answer that question. So the only challenge, we have is not being able to share the substance use information per 42 CFR Part 2 regulations. And we know the state, provides, some guidance as to how to share this information, but we're still, trying to work out, that part. But that is the only, we share all the cans except for the substance abuse information, which you figure child welfare probably already knows, and that might be, the reason why the youth are in the system. So we're still working on that piece.
Yeah, that's built into the state guidance around data sharing between our two systems and probation as well, for that matter. I think I did reference the fact that there, and Kate said as well, there are two different sets of CANS requirements. Between behavioral health has one set of requirements and child welfare the other. Child welfare requirement is a CANS 50 is what it's called, but it's fewer questions than what our behavioral health department is doing, and so that may have been part of the answer to that. What is entered into the child welfare data entry system, the new electronic health record, is just the subset of all of our questions we're doing in Ventura that are applicable to child welfare. But we are looking at everything we're allowed to see except for the substance use information.
I think you answered them all out.
Yeah, did I? Yeah, is that all the questions? They're really good questions.
Yeah.
Any other thoughts, Ventura County? I know we cut a little short. We have some extra time here. If there was anything you didn't get to say earlier.
Kate, I'll throw something out just because I know it's something I think I asked you when we first met, and before this webinar, before this presentation, I actually came off a call locally around work in Ventura County to create a community information exchange, which is being led by our healthcare agency, and both the mechanism for it and eventually the technology for it, similar to what San Diego County is doing. And I think I asked you, how does Opeeka and Pieces potentially interface with other kinds of data sharing platforms and things that I know different counties are looking at, across their systems or may already exist.
Yeah, so I know that other counties are looking at things for referrals, such as like Unite Us or Nine Patch or Julota, and there was another one, Now Pow, Aunt Bertha. So that's for referrals. So we're post referral, so we actually complement with those, and we are working with. Right now with Nine Patch, I don't know if you're familiar with them, they're like a Unite Us, to figure out how to integrate so that we can close the loop post-referral and they can be the care coordination and we can be the care collaboration piece. And we're looking to do that with Sac Valley MedShare around Sacramento County. And that is TBD, to be determined, but we definitely we believe it's going to take a village. We're very collaborative, and we think that all of these technologies need to work together, and so we're very, very open to that, working with any other technology that is in use. Because we are completely data agnostic to the extent that the data must be about a person or family. We cannot capture and do not capture any information about facilities, or anything that's not about a person. We are person questions and answers with answers that change over time. So we're a longitudinal tracking of people and clients' journeys through care and across care agencies within a system of care. So that all being said, there's a lot of different moving parts in there, and we are able to pass information to and from those different systems. And so with Nine Patch, there might be a need for a referral that would come up in our system because, as Jennifer mentioned, there are a lot of alerts. So when a question or a combination of questions gets answers in a particular way, it'll generate an alert that a referral is needed as you have calibrated the system. That can then get sent to Unite Us or Nine Patch or one of those systems. They can manage the referral process and close the loop to make sure that referral process has been completed. And then, should that agency want to receive additional information about the consumer or the client, that request can come back into our system and that information can be shared. We can share via secure email of reports as well in an automated fashion. We do that for Lutheran Social Services, one of our clients, by sharing secure emailed reports to people in the care circle. So we have a lot of different ways to share information in as much of an automated fashion as possible, and we want to work with all the different technologies that support the system of care.